Now that we understand normal hip mechanics and muscle timing, we can begin to analyze gait deviations. Remember, deviations are not random. They are compensatory strategies to reduce demand, avoid pain, or work around restriction. Our job clinically is to identify whether the deviation is the problem or the solution. Trendelenburg gait is characterized by a drop of the pelvis on the contralateral swing side during single limb stance. The primary cause is insufficient force generation or endurance of the stance side hip abductors, most commonly the gluteus medius and minimus. However, pain inhibition from osteoarthritis, greater trochanteric pain syndrome, or post-surgical conditions can also produce this pattern. Neurologic causes include injury to the superior gluteal nerve. Clinically, Trendelenburg gait increases compressive and shear forces at the lumbar spine and increase valgus stress at the knee. Corrective strategies should prioritize stance phase, hip abductor endurance, and neuromuscular control. Corrective exercises would be for the gluteus medius is side-lying hip abduction, clamshells, monster walks with bands. Functional training would be single leg stance with pelvic control, lateral step-ups, and step-downs. Neuromuscular re-education would be having a mirror or biofeedback for cueing to maintain pelvic alignment. A clinical pearl is that a compensated Trendelenburg, where the trunk leans over the stance limb, reduces the external adduction moment but increases spinal loading. Hip hiking is observed as excessive elevation of the pelvis on the swing side. This is almost always a compensation, not a primary hip pathology. Common causes include inadequate knee flexion, limited ankle dorsiflexion, foot drop, or leg length discrepancy. Overactivity of the quadratus lumborum often contributes. Correcting hip hiking requires addressing the underlying restriction or weakness. Corrective exercises, knee mobility drills, ankle dorsiflexion strengthening, core control, focusing on side planks, QL stretching, trunk stabilization work. Functional drills, going on a treadmill, walking, emphasizing symmetrical swing without hiking. If you cue a patient to stop hiking without fixing the cause, they'll simply find another compensation. Circumduction is characterized by the swing limb abducting into a circular arc to clear the foot. This pattern is commonly caused by limited hip flexion, reduced knee flexion, ankle dorsiflexion restriction, or hip flexor weakness. Leg length discrepancy can exacerbate the pattern. Circumduction increases energy cost and places excessive stress on the hip and lumbar spine. Corrective exercises: hip flexor strengthening, such as marching, resisted straight leg raises, high knees with resistance bands. Mobility: dynamic hip flexor and hamstring stretching, and also ankle mobility work. Gait drills, stepping over hurdles, or treadmill walking emphasized on sagittal plane swing. Sagittal plane deficits often show up as frontal plane compensations. An exaggerated anterior pelvic tilt during gait is often accompanied by increased lumbar lordosis. Common causes include tight hip flexors, weak abdominals, poor lumbopelvic control, or neurologic tone. This posture limits effective hip extension and increases lumbar compression. Corrective exercises would be hip flexor stretching, such as the Thomas test stretch, or a half kneeling hip flexor stretch. Core strengthening, such as dead bugs, planks, and pelvic tilts. Glute activation, such as bridges, hip thrusts, step-ups with gluteal cueing. Core strengthening without addressing hip extension mechanics rarely normalizes gait. The posterior pelvic tilt and limited hip extension. This pattern is often seen in individuals with prolonged sitting habits. Weak hip extensors, dominant hamstrings, and reduced hip flexor length contribute to tucked pelvis and shortened stride length. Restoring hip extension mobility is essential before aggressive strengthening. Corrective exercises would include glute max by doing bridges, hip thrusts, or prone hip extension. Dynamic hip flexor mobility, such as a lunging hip flexor stretch, banded hip extension mobilization. Gait drills, exaggerated hip extension walking, or resisted retro walking. A clinical pearl would be, you cannot strengthen your way out of a mobility deficit. An intelligent gait is pain avoidance strategy characterized by shortened stance time on the painful limb. This pattern is commonly seen with hip osteoarthritis, labral pathology, bursitis, or acute injury. Over time, intelligent gait leads to asymmetrical loading and compensatory stress throughout the kinetic chain. Clinical management should prioritize pain modulation and gradual load tolerance before gait retraining. Corrective exercises, partial weight bearing training, or pool walking. Strengthening, progressive glute, quad, and core strengthening. Neuromuscular reeducation would be symmetrical drills, such as a step 2 gait and equal weight shift. You want to normalize the load tolerance before attempting to normalize speed or symmetry. When applying this information clinically, your assessment should include observation of gait speed, stride length, pelvic control, and trunk motion, not just range of motion. Even without force plates or EMG, you can infer muscle demand and timing through careful observation and targeted testing. Early intervention should focus on restoring the ability to handle external moments at each phase of gait, followed by neuromuscular retraining and functional integration. The hip undergoes a coordinated cycle of flexion, extension, and flexion during gait, driven by changing external moments from ground reaction forces. Hip abductors are critical for frontal plane and center of mass control. Hip extensors and flexors play phase-specific roles in sagittal plane control. Gait deviations represent compensatory strategies rather than isolated problems. Effective intervention requires phase-specific, biomechanically justified treatment strategies. If you cannot identify the phase of gait, the dominant external moment, and the muscle responsible for countering it, you can analyze and treat almost any gait deviation you will encounter in practice. Here are the resources. If you have any questions, please email me. Thank you.